So thank you, Chiara, for the introduction. And I just want to second a thanks to Servier for organising this lovely event. So as we described, I'll be focusing on the first and second line. And this is my talk outline. And really what I'm wanting to do today is to cover some of the hot topics which have presented over the last year, and also just with some of in the context of the principles of metastatic colorectal cancer management. So the good news, this slide serves to illustrate, is that you've made a very good career choice. So GI cancer is a great place to be at the moment, and in particular, colorectal cancer. So these are some of the new topics that we are thinking about. And I have to say, compared to 10 years ago, there's a complete paradigm change in our options for our patients. So a good time to be treating colorectal cancer. But the real skill of our job is trying to put all of these options for our patient. So assessing our patient and trying to work out what is the best road for them. And these are some of the things that I'll take into consideration when choosing an option for a patient when I meet them first. I'm not going to go through all of these now, but the workshops actually will provide some really nice opportunities to talk about things like this. But foremost to this is the preference of our patient. And again, the skill of our job is trying to have the guidelines, have the patient in front of us, and then trying to find the right road for the individual patient. So when we discuss the evidence today, of course, we have to be able to apply that to the person in front of us. So whilst we've been on vacation, it has been a busy time for colorectal oncology, and up to, I think it was 3 months ago, these were the ESMO guidelines, but over the summer, they have been updated, which is, of course, lots of work for me because then I need to update all of my slides. And today, what we're going to focus on is the updates in the BRAF mutant and the MSI high patients, which for me was probably the most significant data over the past 6 months. So I'm going to assume that you have a baseline level of knowledge about the BRAF mutant population. Since the Beacon trial and the adoption of encorafenib and cetuximab as standard second-line management, this has been a highly talked about, intense patient population. It is a poor prognostic population, and it's a relatively rare population, but 8 to 12% of the population is still, of course, very significant. But despite the improvements that we did see in Beacon compared to standard of care, there was still a lot of room for improvement in this population. Their outcomes were still worse despite some improvement in their survival with EC. And the Breakwater trial is looking at a series of strategies for BRAF mutant patients. And here they're looking to improve outcomes, I think, with two main ways. Number one, bringing targeted treatments to the upfront management of patients, and number two, combining with chemotherapy. Now, just to go through Breakwater, I'm going to focus on the EC plus FOLFOX versus standard of care comparison because I think that one is the most clinically relevant. Patients recruited to this trial had BRAF mutant metastatic colorectal cancer and hadn't had prior systemic treatment for metastatic disease. The dual primary endpoints were progression-free survival and overall response rate. So I think what we see here is a very convincing improvement in response rate with EC plus FOLFOX compared to standard of care. So not only do we see some really obvious numerical differences, but the other thing that really stood out for me was the duration of response in these patients. So nearly a third of the patients are still responding at 12 months, which again, when you think about the BRAF mutant population, this is really quite remarkable. And then I suppose, unsurprisingly, this is mirrored in the second primary endpoint, progression-free survival, when we're seeing a 5-month difference in PFS. So this is both statistically and clinically significant in my mind. And again, this is an interim analysis of overall survival. And of course, this is a landmark analysis. But again, the curves have separated very convincingly. I'll be very surprised if this doesn't remain positive. And this is really remarkable. So this is a doubling of the overall survival, which is, again, really remarkable, bringing the median OS to 30, which is comparable with other biomarker groups in metastatic colorectal cancer. Why do we think we're seeing such a difference? Did we expect to see such a difference? I think I probably didn't expect to see such a difference. I think this can be explained by a number of things. So number one, what we know is early tumour shrinkage with the response is associated with overall survival. So getting good control of that disease early on, we know has long-lasting impact. And secondly, I think a lot of patients, when you're waiting for the second line, were never exposed to encorafenib and cetuximab, because as we know, these patients, when they progress very quickly, and many of them do not actually make it to second line. So again, this is a really good rationale for giving the best possible treatment up front. In terms of the safety, again, there are unsurprisingly a higher rate of toxicity with the combination. However, if you're used to using these drugs, there were no surprises here. Many of these are quite common side effects that we're used to dealing with EC. So for me, the benefits in terms of the survival certainly outweigh some increased risk of toxicity. So for me, very clear, this is the new standard of care for BRAF mutant metastatic colorectal cancer if you can access it at the moment. In the UK, we currently can't. So I'm going to move on now to another biomarker group of great interest, the MSI-high population. And again, I'm going to assume some baseline knowledge of this group of patients. After Keynote 177, there was a real paradigm change in terms of offering these patients upfront immunotherapy. But again, as we're aware, there were still gains to be made, particularly in terms of this early progression that we saw in 177. So this has then led on to the catchily named Checkmate, and I really struggle to say this, 8HW trial, which then looked at adding the CTLA-4. So again, there's 3 strategies here, and in terms of eligibility for this trial, patients had MSI-high or deficient mismatch repair disease, but they could have they could be at any point of their treatment journey. So this trial did include patients who had had previous chemotherapy, and patients were randomized 2 to 2 to 1 with the dual primary endpoint of PFS in both of the comparisons. Interestingly, the primary endpoint was limited to the centrally confirmed MSI-high population, and we can come back to that. At the last data cutoff, the median follow-up was 47 months, so we do have quite a lot of data now. So this is unsurprising. This is the comparison with chemotherapy, and here we can see an obvious benefit with nivo-ipi. We won't dwell upon that too long. But I think this was the analysis that everybody was most interested. So how much was the CTLA-4 adding to the PD-1? And as you can see, there was a very obvious benefit in terms of progression-free survival in the 2 groups, and this is maintained in the PFS2 as well. And again, we're not seeing the drop-off that we were seeing quite as much in the Keynote 177. Now, just to go back to the point regarding the all randomized patients, what we're seeing is that the effect of the CTLA-4 is seen in the all randomized patients, but I suppose the overall outcomes are a bit worse when you include patients that may not have actually been MSI high to begin with. In terms of the responses, again, we're seeing, convincing benefits with nivo-ipi. And again, when we're looking at that progression group, which we'd talked about in 177, there's actually 10%, and that was compared to nearly 30% in 177. And again, if we're going to do some cross-trial comparisons, which is of course not recommended, we can see that the Pembro response rate was 45%. So again, I think this difference with adding the CTLA-4 is real. Unsurprisingly, there are some increases in immune-mediated adverse events with the combination, but for me, the biggest proportion of these were seen in terms of endocrinopathies, which again, we are used to managing, and I think is something that's reasonable compared to the gains made with the addition of the CTLA-4. But of the toxicities that I think we get most concerned about, there wasn't actually a huge difference between the doublet and the monotherapy. So certainly in my view, again, this represents a new standard of care for many patients. All patients, again, this is maybe something that we can tease out in the workshops. So just to, we haven't talked about the RAS wild type group. Whilst the guidelines haven't changed, there's ongoing data regarding hyper-selection. So can we really tighten our biomarker population that we're delivering this drug to? And this is particularly the case in patients with a right-sided RAS wild-type tumour. So we're pretty convinced that there's a group of those patients that still respond to anti-EGFR, but what we do need is a biomarker to better select them. I think personally that primary tumour location is probably quite a blunt tool. Certainly in the UK, we're running the aerial trial looking at the EGFR ligands to identify those patients, and that trial will soon be opening in Italy, Spain, and Germany. I suppose the only other piece of data that was presented in ASCO in the RAS wild type group was the I want to say tripleti. Am I saying that right? Triplet. I try. I'm British, and essentially this was looking to improve outcomes by looking at triplet chemotherapy versus doublet chemotherapy in combination with the anti-EGFR. And that was building upon promising data from the phase 2 Volfe trial, which had shown increases in response rate and overall survival with the triplet. However, when the trial was initially reported, there was no difference either in response rate or in progression-free survival. But the overall survival data was presented this year, and here they presented an 8-month improvement in overall survival with the triplet plus anti-EGFR compared with the doublet plus anti-EGFR, which was a bit surprising. And the team provided us with all of the data that we would have asked for, so subsequent treatment lines, subsequent local regional treatments, and there was no difference. So I suggest that as one of our panelists is the chief investigator of the trial, instead of me giving my thoughts on it, perhaps we can ask her why she thinks that we are seeing this 8-month difference in overall survival. So we're going to move on from upfront, and by no means do I feel I have told you everything there is to know about upfront, but we have 15 minutes, so we're going to move on. And we're going to change our focus to what to do after induction chemotherapy. I always think this is a really interesting time because patients have had some time to come to terms with their terminal diagnosis. They have had some exposure to chemotherapy. Either it's helped and their symptoms are better, or they've had a lot of toxicity. So there's lots of different ways that people can go after induction. So I always find this a really interesting consultation. And actually, what people are thinking about at this stage is also very different. Some people just want a holiday. Some people just want normality. Some people want to focus on family and be away from the holiday. Some people just want the best available treatment that there is. And some people really don't know, and they're looking to us for advice. And there is lots of data. And again, I could fill a half-hour talk just talking about all the data for maintenance strategies, but I won't. But all of these trials have some pros and cons. There's lots of heterogeneity between them. There's a limited ability to understand subgroups. The endpoints of the trials have been PFS, but actually overall survival, in my view, is the most important endpoint for looking at treatment breaks or maintenance therapy. So the data is quite different, is quite difficult, but this is where ESMO have landed on in terms of maintenance strategies. So in general, it's fluoropyrimidine plus bevacizumab or fluoropyrimidine plus anti-EGFR for those who are RAS wild type. The patients that start on FOLFIRI, the guidelines is just to continue, which I don't think is possibly particularly helpful. What you can do is you can do things like give capecitabine to avoid hospital visits for some patients. And I think there's guidance on maintenance strategies, but again, I personally use treatment breaks. And I think this needs to be considered particularly in patients who have low volume disease, such as asymptomatic lung mets, for example. I use complete treatment breaks quite commonly. Again, this is a perfect example of personalized medicine and where the skill of the clinician really comes in. And again, the other concept that we're thinking about in oncology is lines of treatment and should actually be thinking about a continuum of care rather than the traditional first, second, third line. And again, I think this will come out in the workshops as well. And these are some of the things that make you think, well, after maintenance or after a treatment break, actually is this reintroduction of induction versus second line, and which way should you go? So very briefly on second line, I always think this is slightly the poor relative in metastatic colorectal cancer. There's lots of data in the upfront setting. There's lots of data in the refractory setting, but actually there's not a huge amount of data in the second line. And of course, this is an important part. But this can mainly be summed up by switching. So basically a light switch, you start with FOLFOX, you move to FOLFIRI. Hopefully it will become more interesting in the next couple of years. Again, there's data in specific biomarker groups. So in the MSI high or the BRAF mutant group, of course, second line can include targeted therapy. But as much as possible, I would be offering these to patients in the upfront setting. So just very briefly to finish, one very important part of the metastatic colorectal cancer pathway is the multidisciplinary team. And at various points of the pathway, surgical or localized therapies can be offered to patients. And again, this could fill a half-hour conversation, but what we'll talk about just briefly is the other really important piece of data which has transpired recently, which is the TransMet trial and thinking about liver transplant in selected patients. So this trial included patients who had unresectable but liver metastases, but no disease elsewhere. And they were put forward by their own tumour board to a central MDT who then assessed them for eligibility. And patients were randomised either into the liver transplant plus chemotherapy arm or the chemotherapy arm alone. Patients had to have, of course, their primary tumour resected, and they had to have partial response or stability with over 3 months of chemo, which is quite a small amount of chemo. Certainly the criteria in the UK is a lot longer than that, requiring stability for, I think it's nearly 2 years, although we're trying to get that down. However, the trial met its primary endpoint of 5-year overall survival, again, extremely convincingly, with a huge advantage in terms of overall survival in those who underwent a transplant. However, what we did see was that over 2/3 of patients did have disease recurrence, so it didn't cure them in the vast majority of patients, but most of these recurrences were in the lungs, and then patients went on to, say, have another ablation or resection. And there's still 15 patients with no evaluable disease. It will be important to see longer-term follow-up in these patients. But there's obviously quite a lot of complexities relating to this, and I think each country is going to have their individual challenge in terms of implementation, with organ availability and the outcomes of these patients compared with other transplant indications. And again, we'll wait to see further longer-term follow-up. So my conclusions is that we're making major progress in the management of metastatic colorectal cancer. We've seen some paradigm changes. However, a large proportion of our patients still don't have an actionable molecular alteration. Remember, the MDT is critical, not just at the start of the pathway, but also going back to the MDT to ask the questions about potential local therapies. And I think it's important to consider this evolving concept of the continuum of care. And so on that note, I shall pass over to Dominic to talk about refractory disease.
Good morning, everyone. Thank you for the nice giving over to me. My job is to cover third line and beyond treatment opportunities for MCRC patients. I'd like to start with a bit of background and a bit of theoretical assessment of third line. I'd like to focus on 2 evaluations, one of the TRIBE trials and the other one I think was a rather historic of the FIRE3 trial, just to highlight what the role of third line therapy for the majority of the patient is. What you can easily see is that third line is an indication which affects approximately half of the population. And on the right, if you look into the gray curves, the majority of the patients that make it to third line reach that point pretty early, at least earlier than some of us would think. So the majority arrives there between 1 year and 1.5 years after starting first-line therapy. So it's a quite relevant proportion of the patients that receives the therapy, and also I think we can agree on the fact that within the first 1-2 years, usually these patients are considerably fit. What are typical characteristics of third line or beyond therapies? Of course, you can argue on many details and also definitions that are not always consistent, but I think in general, of course, if you talk about third line, 2 other regimens should have been used. We can, of course, discuss what to do after FOLFOXIRI if you have used all 3 cytotoxics or classic cytotoxics in the first line. Does maintenance therapy count? You never know. I think that VEGF substances should have been used before to define a third line setting, and of course targeted agents like EGFR antibodies, BRAF inhibitors, and maybe also checkpoint inhibitors should have been used. But I think we can all agree that while third line is easy to define for the majority of the patients, there will always be cases that because of biology or treatment sequence are not easily defined as third line patients and might arrive in a third line scenario as second line patients or as fourth line patients, depending on what they have received before. So historically, in the development of treatment options in metastatic colorectal cancer, we've had only 3 options that were usually done. We had first line, maybe including maintenance trials. We had second line trials. We haven't seen so many in recent years because that was a traditionally unsuccessful area of development. And also third line and later line trials, which were a big box. So starting from third line, it was called later line therapy, and we've of course had a lot of single agent developments. If you look into the living guidelines at the moment, the recommendations, as you can see, are quite diverse and cover everything that is labeled, and I will just try to make a bit order into that recommendations. There are also some recommendations that are not so easy to understand or not even labeled or even evaluated, like cetuximab adagrasib, which has only been evaluated in a non-randomized trial. So we hope that these things stay that way and receive a bit more evidence to support. So classic third line and later line scenarios, I think we make it very quick because you're all aware. I think we have 3 substances that have been evaluated in very, very similar trials. The first one was regorafenib with a slight improvement in overall survival and a respective hazard ratio of 0.77. Then we had trifluridine tipiracil evaluated in a very similar trial with a bit more efficacy and also better tolerability. And just recently we had the 2 FRESCO trials. I only depicted the second one because it was the only relevant for us, being a global trial, with even a bit more gain in the median overall survival and also a very similar hazard ratio for overall survival as the RECOURSE trial. Having said that, I think the next step in the development of third line was to try combinations in that setting. And of course, trifluridine tipiracil as a fluoropyrimidine derivative was a good candidate to be combined with bevacizumab, which we know works, at least theoretically, beyond progression, and it does not cause classic resistance or intrinsic resistance in the tumors. And I think this is one of the rare examples where a second-line trial was delivering a hypothesis that was so robust that it was transferable on a one-to-one fashion nearly, with a restriction that it was clearly a third-line trial, into a phase 3 design, which was the Sunlight trial, which was a very straightforward trial. It wasn't too big, around 500 patients. It was comparing trifluridine tipiracil bev versus the chemotherapy alone. Primary endpoint, I think consequently in a third-line setting, was overall survival with very classical endpoints as secondary endpoints. The efficacy analysis in the Sunlight trial was very, very consistent in a way because all time to event endpoint were improved by approximately 3 months, a bit more than 3 months, with hazard ratios that were, at least from my point of view, surprisingly strong, with a hazard ratio for overall survival of 0.6 and 0.44 for progression-free survival. Of course, both endpoints were clearly met and improved significantly. Interestingly, and maybe also counterintuitively, there was no formal interaction between prior bevacizumab use or not. Of course, you can argue that at least from the majority of European countries or countries all over the world, the majority of patients would have had bevacizumab before entering such a third-line scenario. And you can also, of course, argue that the hazard ratio for bevacizumab naive patients is a bit stronger than for pretreated patients, but still the effect is entirely the same, or not the same, but significant with pretreatment of bevacizumab. So I think this group of special interest did not support the idea that this is a drug that is primarily working in naive patients, so no formal interaction with pre-therapy. Additionally, whenever adding a drug, of course, bevacizumab is maybe not suspect to many side effects. You also have to evaluate or fear that, of course, this additional drug impairs quality of life, which was clearly not the case in the SUNLIGHT trial. So if you look into the key assessments of the ERTC questionnaire, you do not see any kind of changes in global health status or other key issues that were assessed. So if you put that into perspective with the classic one-on-one randomized or placebo-controlled trials, you see that the gain in median overall survival and also the hazard ratio of overall survival is the strongest in that case. Of course, we do not make formal comparisons, just like I did a second ago, but I think if you put into perspective and also take into consideration that this is an active control trial, so this is the only later-line trial, at least up to now, in a classic third-line setting that has an active control, with the exception of smaller trials like Footbrake 300. And I think taking that into consideration and looking at the treatment options, that's a quite strong signal. One aspect that raised at least some discussion, maybe not criticism, but discussion, was the low overall objective response rate that was observed in the SUNLIGHT trial. It was considerably small, less than 10%. However, if you look into these very actual data that were published by GN, looking at the waterfall plots, you can easily see that this is not the true story or not the whole story, and that a quite relevant proportion of the patients actually had tumor shrinkage, but not making the threshold of 30% to declare objective response. But I think if you look into the comparison and also how little patients manage to have tumor reduction with a monotherapy and how that extends, also reducing the amount of progressive patients and the extent of progression, I think these plots explain very well how these time to event points were reached. So what are the alternatives that we have today and also on the horizon? We touched briefly on a few options. Of course, EGFR re-challenge is a topic that is, I think, discussed for 13 years now. I think the first paper on that topic was 2012, which was maybe just hypothesis generating, but we have seen a lot of trials now and also the first randomized trials, making that whole story even more complex. I think one of the really good proof of principle trials was one of the two Italians, the Kronos trial, addressing pre-characterized patients being all wild type with a liquid biopsy that were re-exposed to panitumumab with a quite good response rate of around 30%, which I think is a good activity considering that you have used the drug before. However, this summer made it a bit more complex. I'm just showing two trials. One trial that was done by my working group, the FIRE4 trial, which was criticized heavily, maybe with good reason or not, because it randomized the reintroduction or re-challenge. It was a mixture of patients to investigator's choice. It was a really problematic trial because the accrual didn't work the way it was supposed. And of course, running a randomized trial across 3 lines of therapy was maybe a bit over-ambitious. However, the signal that comes out of this analysis of investigator's choice versus EGFR re-challenge is absolutely none. So there is no indication that EGFR re-challenge is better than whatever was done as investigator's choice, which, and that's maybe the important thing, was not monotherapies, at least for the majority monotherapies with trifluridine, tipiracil, or regorafenib. There were a lot of combination chemotherapy uses as reintroduction or re-challenges as the comparator arm. A cleaner design to assess the value of EGFR re-challenge was used by the Parere trial. It was randomized versus regorafenib. Of course, in that case, you can argue from today's perspective that while this was maybe the standard when the trial was started, it may not be the ideal comparison from today's perspective. However, the trial also incorporated the crossover to the respective other drug in a kind of post re-challenge situation. There are no overall survival data yet available, and the signal that was received from that trial is quite good. There's a small improvement in progression-free survival and a clear improvement, at least from my clinical point of view, in objective response rate, somehow confirming, although not on the level that was maybe expected, that this treatment option at least delivers some objective response rates that exceed what we can expect with classic third-line or beyond drugs. Having said that, I think we can agree that a completely and final conclusion on the value of this EGFR re-challenge strategy is not yet mature. What else can we do? We have some targeted options that are recommended by many guidelines for many years, still not labeled, in some countries not available. One of them is targeting HER2. I think the knowledge that HER2 identification is possible in metastatic colorectal cancer is known for more than a decade. I think we have hardly had an ASCO without a new cohort, a new compound, a new evaluation with that topic. And unsurprisingly, the data are quite robust. One of the latest editions of that HER2 story was the Mountaineer trial with a high objective response rate combining tucatinib and trastuzumab in these respective patients. And as you can see in the spaghetti plot, that there are quite a few responses that are really durable in terms of lasting for more than a year, some more even 2 years, and in some single individuals even reaching a 3-year follow-up in terms of ongoing response. Similar data, although in a bit smaller cohort, were reported for trastuzumab deruxtecan in HER2-expressing metastatic colorectal cancer. Unfortunately, that drug isn't evaluated in a randomized fashion anymore. In that indication, there's an IIT from Italy exploring that within the first-line setting as a proof of principle trial, so I'm looking very much forward to that one. But I think if you look into the waterfall plot, we can agree that the promise, or at least the hypothesis, that this drug is adding a benefit to patients is maybe very similar to trastuzumab and tucatinib as a combination. The only really available data in terms of randomization in a setting that was declared further line, it was not classic third line, was the CodeBreak 300 trial. Many of you are aware of the trial. Interestingly, it was a phase 3-arm trial with 160 participants, which may somehow explain that the limited evidence that was deducted from that trial was maybe part of the design. I think the company completely underestimated the recruitment potential of that trial because they were not kind of expecting that this trial would be really feasible, and I think in the end the recruitment was finished in less than half of the time they estimated. So highlighting somehow the medical need for pretreatment patients to have targeted agents available. The trial compared 2 doses of sotorasib with classic doses of panitumumab, comparing to investigator's choice, which again, from today's perspective, is maybe not the optimal choice, being trifluridine-tipiracil or regorafenib. The primary endpoint of the trial was met, especially with a high dose of sotorasib, but as you are all aware, the secondary endpoint of this trial was overall survival, which was evaluated in a fashion that was mature from a protocol point of view, but I think from a clinical point of view, with 50% of the endpoint in a 160-patient trial, did not deliver really statistical robustness to analyze this overall survival, suggesting that up to today, we do not have any proof that this drug combination really extends survival despite this signal in progression-free survival. So what are the takeaways from my presentation? Trifluridine-tipiracil plus BEV, so what we call the Sunlight regimen, is the only prospectively randomized phase 3 third-line trial. It's the first. And I think it's a standard of care in this situation with good efficacy, maintain quality of life, and also, of course, allowing many patients treatment beyond progression to that regimen. Of course, alternatives for third line and beyond patients are targeted therapies if they are available in the respective molecular subgroup. And of course, also fruquintinib appears more active and less toxic as compared to regorafenib and is a clear standard from fourth line and beyond. Re-challenge with anti-EGFR, I think, is a topic that will stay for a few more years until we have the final evaluation of some trials that are still going to the follow-up phase. And I think as we did in the past years, with careful consideration and selection on using also ctDNA to characterize patients for being really wild type, is something that we can use in at least a subgroup of the patients. And of course, personalized decisions, as Jenny also pointed out, are key, especially in third line and beyond. And I think with that, I've made up 2 minutes.
Before concluding, I think we are going to have a time for discussion. Please ask some question, because for now, no question is coming. I will have a first question for you, Chiara. So, what is your insight on the triplet last results, of course? Because the triplet plus anti-EGFR was more or less out of the game since the first presentation you made and other studies, and now we have this overall survival coming. So how can we explain that, and what will be your recommendation?
The first answer is that I don't know. I mean, these data were surprising also for us. I remember at an Italian meeting there was a discussion about triplet, and it was deemed granitically negative based on activity and progression-free survival data. What can we say? There is a clear difference in post-progression survival. We investigated, as Jenny pointed out, if there was an imbalance in the quantity and quality of treatments received after progression, but this does not appear to be the explanation. Maybe patients treated up front with the triplet at the time of disease progression do have a lower tumor volume, a low tumor burden as compared to those progressing after doublet plus panitumumab. But actually we do not have this demonstration. We will work on that not only at the CT scan levels but also measuring the tumor fraction in plasma, since we have longitudinal assessments of plasma for these patients, but actually these are more hypotheses than real explanations. For sure, we used this new RECIST. It's not new anymore, but it's RECIST 1.1. And as compared to RECIST 1.0, they allow to depict the overall burden of the disease with lower accuracy, because with the RECIST 1.0 we had 10 targeted lesions, up to 5 per organ. Now we have up to 5 target lesions overall and not more than 2 per organ. As a consequence, if you have a patient with a huge liver involvement and many nodes or many lung metastases, then you are not able to find out a tumor shrinkage so relevant in such a precise way as you were able to do with the RECIST 1.0. But as I mentioned, it's just an explanation. However, this 8 months difference in OS is real, and I think we cannot forget to somehow think about that in some selected patients.
So which patient will you treat with a triplet and anti-EGFR today?
My problem with the triplet plus anti-EGFR, that using also in the frame of the trial, I remember really amazing responses. I mean, very quick, very deep tumor shrinkage after 3-4 cycles of therapy. So I would think of those patients with a very, very relevant tumor burden that really need to respond as quickly as possible, and the young patients, because although we used the lower doses of irinotecan and 5-FU, still the problem of gastrointestinal toxicity and in particular diarrhea was there. So I think that a careful patient selection in terms of what happens in the case he has diarrhea, okay, he will recover, we will continue the treatment with lower doses, okay, that's fine. Otherwise, for more frail, that means in this case average frail patients, I will not think of that option.
Yeah, it's true that it's not completely easy to tolerate. Thank you, Chiara. I got a question for Jenny on breakwater. So if you got a patient coming with neuropathy and previous FOLFOX, BRAF mutant, what would be your best choice, whatever the reimbursement is? We don't take care about the money story.
I mean, I personally think that the upfront FOLFOX is a real problem for all of those reasons. I personally will use a lot of irinotecan in the first line, and there is a comparison in Breakwater, and there is data from the phase 2 component looking at irinotecan. So personally, I think I would be quite comfortable if I was able to give the combination with FOLFIRI based upon the safety and the efficacy data. But we will see that data. I don't know if anyone here knows when that data is expected, but Breakwater has been a rolling program in terms of the different combinations that are being looked at. But if somebody already has neuropathy, you can't expose them to FOLFOX. I mean, you could drop the oxaliplatin, I suppose, which would probably be the licensed thing that you could do in that situation.
And we also had very nice preliminary result on the 30 patients of the safety lead-in treated with FOLFIRI that were really promising.
Exactly.
Whatever they were first or second line, they were really outside what we were expecting. And there is 2 FOLFIRI cohorts that are coming that will complete the data and maybe super useful. There is another question for Breakwater from the audience. So can you explain why EC is improving PFS as compared to standard chemotherapy, but not OS? The arm that was discontinued with encorafenib and cetuximab alone without chemotherapy is doing better in terms of PFS and also response rate, by the way, as compared to standard chemotherapy. But it's true that OS, I think, moved from 15 to 19. I think it's not so bad. Yeah.
There was an advantage in OS.
And not in PFS, okay. But it's written the other way, yeah. Because the OS is 4 months difference, so it's not so bad.
Yeah. Yeah, that's what I was getting confused there. Yeah.
Yeah.
I think you've answered the question.
Okay, and I have one for Dominic, and I give you the mic. Dominic, I have a question now. You showed our last publication on the shrinkage with trifluridine, tipiracil, and Bev, which is not so small. And for a long time, we said that maybe when we want to re-challenge, we need a bit of shrinkage, maybe anti-EGFR re-challenge would be better. But we see also with all these studies, Racintro, the last study from Chiara, the Japanese study, that the response rate is not 25 or 30% in EGFR re-challenge. So today, would you prefer does it change your opinion on sequencing re-challenge and trifluridine tipiracil plus Bev or not?
I think it modifies a bit the perception. If you look on that on a very formal level, I think the level of evidence for trifluridine tipiracil plus Bev is still better because it's a randomized phase 3. I think the true response rate, as you say, is not 30%, but maybe in the range of 10 to 15. More or less, depending on the cohort, whether it's true refractory cases or if it's reinduction cases, although these cohorts are not really consistent with each other. Also explain that there's a certain range in the response rates. But I think the good news is you have the choice, and if EGFR re-challenge isn't reimbursed, as in many countries, I think you are even more confident to use the Sunlight regimen, also taking into account that many patients are able to receive the EGFR re-challenge after that, maybe even extending the window therapy time frame and allowing for more tumors to restore themselves in a way that the EGFR antibody can work. So I think it modifies a bit the perspective, and I think I would use more, or I started to use more trifluridine tipiracil plus Bev than I did before, but I wouldn't say it's a black and white story.
Dominic, there is another question about this topic of anti-GFR challenge, because as you mentioned, there are some gray areas in this space. And the question is about these conflicting data, considering also Kronos, Parere, and Remerri, that was presented at ASCO this year as well. So as a conclusion, would you recommend using ctDNA to guide the therapy in the case you think of reusing an anti-GFR? Is it needed? Hopeful? What do you think?
Okay, if you have access, of course it's helpful, and of course I think the data that are available suggests that you can select better. However, you can also make the reverse case and say in many of these trials, it is absolutely not clear that they are truly re-challenged trials, because I think many of these trials also have patients included where an initial progression was not clearly documented, and this is more a reinduction. And of course, if you know you have a patient that is not truly refractory and you think about using EGFR for a second time in the third or fourth line, you can argue that a new characterization is not necessary without documented progression. Also taking into account that many don't have access.
I personally agree with the idea that having access for sure, doing liquid biopsy is the best thing. These clinical characteristics of potential anti-GFR sensitivity, for example, you did not progress during the treatment, but off treatment, are not reliable 100%. In the Parere trial, there were patients in the re-challenge setting, patients in the reintroduction setting that did not experience disease progression during anti-GFR upfront. Of course, we found more ctDNA mutants among patients that progressed during the treatment, but it was not 100%. So I think that for each individual patient, having the opportunity to test and working for that, also considering that the cost is really limited, it's a PCR, I think we should work towards that direction.
But I think it's also part of the story that the sensitivity and the specificity to test these mutations and to reintroduce the drug or rechallenge the drug is considerably low. So I think we also have to admit that even characterizing for these mutations does not kind of predict any kind of efficacy. So I think the holy grail to characterize is even not reached with ctDNA. So it's a good thing, but it doesn't really solve the problem.
There are two other questions that I will take on MSI and BRAF patients. So no doubt, one question is, do we start with immunotherapy in all cases? I think that there is no doubt that except a very severe contraindication to immune checkpoint blockers, you start with immunotherapy due to the good results in a large number of patients as shown by Jenny. And the second one is, are we allowed to do FOLFOX encorafenib and cetuximab in the future in patients pre-treated with immunotherapy? So we don't have any answer to that because, of course, this combination is completely new. But we have produced last year a paper with a KRAS group and friends showing that encorafenib and cetuximab in second line after immunotherapy was performing as good as after chemotherapy. So I think there is no reason not to use the breakwater regimen in MSI high patients failing with immune checkpoint inhibitors. Okay.
Another question is about MSI high upfront, the MMR. Jenny touched on this. A practical question. When we have Ipi/Nivo available, then is there still a space for Pembro alone? How would you choose?
I have been mainly using the combination in most people that I think are fit for chemotherapy. The problem with clinical trials is that they usually don't represent the kind of the extremes of our population. So they won't include particularly older patients, patients with comorbidities. And so we don't really have great data for those groups of patients. So I have recently given Nivo/Ipi to somebody in their mid-70s. They did okay. I think when you get towards 80, and remember that actually MSI-high is enriched often in older patients, right-sided tumours, so there are many of these patients. And many of them have done very well on Pembro alone. If we think about these people over the past the past 5 years of treating, we've seen people do really well on Pembro alone. So whilst I've been offering it to most people that would have fitted the trial population, I'm a bit more reserved in older patients at the moment. What I hope is that we'll get more kind of real world data, not just on the efficacy in those patients, but also in the tolerability as time goes on.
There is another question about MSI-high patients. In the case of very good response to immunotherapy and potential of resectability, is better surgery, continuing the treatment with immune checkpoint inhibitors. Another gold question is the duration of the treatment for these patients.
Yeah, so ATHW has tied us again into 2 years of treatment, like 177 did. And do we need 2 years of treatment? I'm not sure, particularly in patients that have done very well to begin with. And I can think about a handful of patients that either have gone for surgical resection or who have not gone for surgical resection. And again, they are quite a small biomarker group, and so pooling all of our data is really important. But I have an older patient, she's in her 80s now, and she had some lymph nodes that we gave her Pembro for 2 years. We haven't resected them. We continue to not resect them. We do CT scans every 2 years. I suspect that she has some acellular tissue left, but it's very difficult.
I think you're pragmatic, and it's the way we have to do. I think it's a single lesion in the liver that you can treat by thermoablation easily. Probably we will destroy it. If it's a sacrifice of the parenchyma that is important, or a complex surgery with lymph node, etc., I think surveillance is completely adequate, because we have seen a lot of patients resected after immunotherapy that were with no evidence of disease on the pathological specimen first, even if sometimes there is still something in a complete responder. We have seen also that once. So I think we have to go to the conclusion. This session conclusion. So you've understood that colorectal cancer is frequent and severe. This is a major health problem in many countries. We still have this debate initially between response, tolerability, and of course survival. That is always our goal, whatever the situation is. And of course, in frail patient, maybe tolerability will be a major issue. In patient potentially resectable, response will be a major issue. So we have to deal, and I cannot repeat enough that multidisciplinary is super important. And if we go to the whole algorithm of colorectal cancer, that patients have to be classified as resectable, potentially resectable, or non-resectable, re-evaluate your patient, have a really specialized surgeon of the liver in your team or outside your team to refer your files, because it's really important. And we see even now patients with 1 or 2 years of therapy that were resectable and never discussed for surgery. Liver transplantation is a new option. Of course, it raises more questions than it solves. In my unit this year, we have been able to transplant 3 patients, but now the biomedicine agency who is delivering the organ in France is stopping because they don't want too many cancer to give the liver, because you are prioritized when you have a cancer. This is the idea of Transmet, but it is an option and can be discussed in potentially the country that are potentially able to make it. You understood also that the picture that was super simple 20 years ago, FOLFOX, FOLFIRI, or FOLFIRI, FOLFOX, has changed a lot, and that we have now all these molecular biomarkers that we have to assess upfront, I think clearly, and I think very soon more markers are going to come. Sidedness remains something interesting, even maybe if in the future we are going to have large panels to assist the molecular alteration of each patient, and maybe we will get rid of this sidedness story, but for now it's still important and have to be considered in the choose of your first-line treatment. And you got a lot, and every year more theranostic implication of some mutations that are coming. So the next one is probably HER2 that is currently explored. KRAS inhibitor also very weighted, of course, because it's a large proportion of our patients. So from the scenario a few years ago with 3 possibilities like doublet anti-EGFR, doublet anti-angiogenic, or triplet anti-angiogenic, we moved to 5 different scenarios depending on your molecular alteration, and especially because the emergence of new treatment for BRAF mutant and MSI high patients. And you can see that whatever you're doing in the third-line setting, trifluridine, tipiracil, and Bev is generally the preferred choice in patients able to receive this treatment. It's also a very well-tolerated treatment that is easy to administrate, and the main problem, as you know, is neutropenia that is also easy to manage or even to prevent. The only situation is the very small group of MSI and BRAF mutant that we discussed a bit, that will have probably no chemotherapy up front with only immunotherapy, then probably in the future the breakwater regimen, and then another chemotherapy before moving in the 4th line to trifluridine, tipiracil, and Bev. And I think the oral drug that have proven efficacy will generally be used afterwards. In the future, of course, there is a lot of development. You know that studies are going on immunotherapy for selected subgroups of microsatellite stable patients. That, of course, specific G12C are there, but it's very rare. It's less than 3% of our patients, so not easy to find them. And the success of CodeBreak 300 is there, but the overall survival was a bit disappointing. So we are waiting a lot from G12D, which is much more frequent in colorectal cancer, and pan-RAS inhibitor. The universe of RAS mutation inhibitor is quite complex and will be developed in the next ESMO meeting. HER2 targeting agent, as I said, we have many of them. Zanidatamab, tucatinib, and trastuzumab deruxtecan have given some interesting results in pretreated colorectal cancer. Antibody drug conjugate, again, a lot of them are coming, and phase 3 trials are going to be launched soon in the colorectal cancer space, and also bispecific antibody that are also coming to colorectal for phase 3 first and second line trial in the near future. So we hope that with all that in 10 years, we will again perform and transform the prognosis of our patients. And to conclude, and the major takeaway of this session, I think, is that we have done a lot of progress, not enough, of course, but it has really changed during the last 10 years, especially with MSI and BRAF, but not only. It's important to identify actionable alteration and to match the therapy for them. Trifluridine, tipiracil, and Bev is the only phase 3 targeting specifically third-line patients, and versus an active treatment, not versus a placebo. Alternative third-line options are mainly guided again by molecular alteration, but of course, all this treatment, as you have seen for BRAF, are moving from the third line to the first line as soon as they can. So I'm not sure it's going to be competing a long time for third line. And multidisciplinarity remains really fundamental in the management of our patients. And with this, I thank you.